All right. Well, thank you very much for having me on the show and letting me participate in PerfWeb number 26. Joe invited me to come talk about a little bit about AngioVac, and with that, we'll get going. I do apologize for the glare in the background. Tough time in the day with the office and the sun location, but hopefully it's not too bad for everybody. Next slide. So AngioVac, for those of you who do not know, in its simplest form is a vacuum for your veins. It is indicated as a venous drainage cannula for the removal of fresh, soft thrombi and emboli during extracorporeal bypass for up to 6 hours. Next slide. We'll get into a little bit more of what it's indicated for as we move along and talk about how it's used. But you can see here in the top left-hand corner the two business end options for the AngioVac platform. These represent the two cannula shapes that we offer for the system. It is a 20-degree angle tip and a straight tip. And then in the lower left-hand corner, you see the circuitry and the other components that go along with the system. Like I mentioned earlier, in its simplest form, AngioVac is a vacuum for your veins, and for every milliliter or cc of blood that's aspirated from the body, it's filtered and simultaneously reinfused. So I thought what made the most sense is really to kick off with where the device started. Next slide, please. So AngioVac was invented in 2008 by a company called Vortex Medical. This was established by two cardiothoracic surgeons in the Boston area. They were doing an open surgical embolectomy case and were literally tweezing clot out of the lungs with pickups, and we're discussing the possibility of using wall suction in a case like that to facilitate the removal of some of that material from the pulmonary arteries, and that's really where the AngioVac concept was born. So they received 510(k) clearance for the first iteration of the device, the first generation device, in 2009, and started doing cases in 2011. AngioDynamics came into the fold in 2012 and purchased Vortex for $55 million in the late 2012 timeframe, and subsequently then transitioned into next generations, expanded indications, and kind of where we are today. So if we go to the next slide, we see here a little bit more the path the device took and the platform took with respect to labeling, acquisition, and the generation of the device we see in the market today. After AngioDynamics acquired the device, obviously the venous drainage cannula indication, while very broad and covers a lot of different areas, is very limiting in the sense that it's not specifically indicated for any one disease state. And AngioDynamics did the clinical work necessary to expand the indication to include specific anatomies that we'll talk about here in a little bit, as well as the disease state around fresh, soft thrombi or emboli, which is really what drove where the device is being used today. And subsequently, we launched the AngioVac Generation 2 device, which is on the market today, and later this fall we'll be launching the third generation of the platform. So now we'll get into a little bit of how it works. Next slide, please. So as we mentioned, it is a veno-veno bypass circuit, but the business end, the AngioVac cannula itself, is a 22 French balloon-actuated stainless steel coiled cannula. So what we see here is the tip entering a vessel, utilizing an endoflator, 50-50-ish mix with contrast depending on preference, to inflate the balloon and create the funnel or tulip that makes the distal end or distal tip of the AngioVac cannula, allowing material to be toothpasted into the system. So the device is pretty large, 22 French, but it's that big for a reason, right? And we'll get into a little bit more about that down the road in the presentation. Next slide, please. So here we see a sort of a schematic of the way the AngioVac system is set up and operating. You can see here that we're aspirating out of the right jugular vein, filtering it, and simultaneously reinfusing it into the right femoral vein. This is driven by your off-the-shelf centrifugal pump. So whatever manufacturer you use within the hospital or your perfusion team uses within your facility, as long as it's a 3/8 inch in and outflow, that will support the AngioVac platform. You can really use any combination of 4 access points. Obviously, you see the right jugular and femoral utilized here, but you can use any combination of the jugulars or femorals, so the right or left, based on what you're really trying to accomplish in the case, what anatomy you're targeting, what hardware or stenoses you may have to accommodate when you're choosing access points. Obviously, if there's a stent or something like that in the right side and in the jugular, we may not choose that location for access and choose another accordingly. Basically, you're going to choose the site that optimizes your ability to navigate to the point where the undesirable intravascular material resides, and always, when possible, come from a place of embolic protection. And what I mean by that is simply that if the material you're trying to remove resides below the right atrium and IVC junction, you'd likely come from aspiration from above to protect any material from slipping past the cannula and embolizing to the lungs. On the same sort of same line of thought, if the burden you're trying to remove resides above the right atrium and SVC junction, you may want to come from below with the AngioVac device to try and remove the material prior to it embolizing into the heart and further into the lungs. Next slide, please. Mentioned earlier that this is a veno-veno bypass, so from a perfusion standpoint, this is the easiest circuit you guys are going to build in a day. We have no heater, no reservoir, no oxygenator that you need to manage or deal with. This is simply access in 2 places to aspirate, filter, and reinfuse. Obviously, the circuitry can be made much more complex depending on what we're trying to accomplish, but from a straightforward on-label setup, veno-veno bypass, pretty straightforward for you all, but kind of gives you an idea of what we're working with here. Next slide, please. Mentioned that we're currently on the 2nd iteration of the device, and for those of you that have been supporting the platform or have experienced with the platform from the beginning, there has been some significant changes made to the platform, starting with the cannula itself. Originally was launched with a single shape, a straight cannula, which sort of limited your ability to not necessarily steer, but provide some directionality and bias within the vessel or vasculature as you're driving it to where it needs to go. Additionally, the original device didn't really have any radiopaque markers on the distal end of the platform. So from a visualization standpoint under imaging, the RO markers on the tips of the pedals make it a lot easier for us to position the product appropriately and position the cannula in a place where it's most likely to aspirate the material you're targeting. And then next slide, please. From a circuitry standpoint, added a true over-the-wire Y adapter, which allows, obviously a much safer deployment of the system as we use the rail system to navigate and drive the system where it ultimately needs to go. Next slide, please. From a bigger picture standpoint, obviously we've talked about the cannula and circuit separately, but they do marry and create one system. In addition to the components that come with the AngioVac platform, there are some additional components that will need to be considered. Some type of inflation device to manage the the cannula and the balloon itself. Your access kits, dilator sets that you'll use to dilate, obviously up to the access sizes we need for the AngioVac cannula and reinfusion cannula. Typically, we recommend an arterial reinfusion cannula because it generally offers an additional de-airing port, which is really just a nice-to-have safety option as you're setting up, so that if you do have some air enter the system from anywhere, you have the ability to clamp and de-air without having to deprime or anything like that. And then lastly, we recommend a 26 French access sheath. Again, from a first glance, 26 French seems relatively large, but again, it's that big for a reason. And oftentimes, folks that have a significant amount of experience with the platform often ask for a larger device. Next size, please. Or next slide, please. So obviously, been talking about how big the device is, and like I said, it's that big for a reason. The vessels that the AngioVac plays in and the chambers in the heart what the AngioVac operates in are relatively large with respect to the other vessels in the body, and the current options that are out there to remove some of this material often don't allow for the size of burden we encounter in some of these situations. So again, the AngioVac cannula and system is as big as it is for a reason, and allows for the removal of larger material as we attack some of these burdens. Next slide, please. And just to kind of talk a little bit about how AngioVac is deployed and what we're thinking about as we utilize the device. As you gain access and drive your wire to the location you ultimately will place AngioVac, you will follow the funnel, or excuse me, follow the wire with the cannula and funnel accordingly. Use the end deflator or inflation device to inflate the funnel itself to open the distal tip and create that opportunity for material to be toothpasted into the system. Initiate the flow on your pump to start establishing some negative pressure, and you start moving the cannula towards the burden. And this is where you'll notice a significant tactile feel and difference between what we refer to as chugging, and as you encounter material, you'll feel a really non-rhythmic chug, and that's the cannula itself and the system itself engaging with the undesirable material you're aspirating. And that's different than like the cavitation of a vessel if the negative pressure may be too high. And what you'll see with cavitation of the vessel is you'll see a much more rhythmic collection and release of the negative pressure. And that allows you to understand the difference between engaging actual material you're trying to remove and aspirate, and whether the negative pressure is too high and actually collapsing the vessel. And if that occurs, all we really need to do is just back off the negative pressure slightly to maintain the highest negative pressure we can without risking closing the vessel or anything like that. And the reason for that is really flow is our friend here. Next slide, please. And as we build negative pressure, it really allows the system to kind of do its thing and build up the pressure necessary to aspirate this material. I'm sure a lot of you have seen some of the pictures of cases done with AngioVac on Twitter or LinkedIn. And sometimes these clots are very large, just large pieces of material, and it doesn't just get removed immediately. It takes time for that pressure to build up and create the suction necessary to remove it from the system. So I've got a couple videos here to kind of help demonstrate how the AngioVac does its thing. So we'll start with a benchtop video what we have here for you. Next slide, please. And if we could hit play. And obviously, this is just a tube that's going to demonstrate the AngioVac concept and how it works to toothpaste that material into the system, but gives you an idea of the concept and the functionality of the device itself. We'll start here with this benchtop example and then show a couple animal models we have for you to demonstrate how this procedure actually works. And obviously, the larger pieces took a little bit more work as the material got conformed to the inside of the funnel and ultimately then went. As we encountered some of the smaller pieces after the large first chunk was taken, obviously aspirated much easier and kind of flew out of there relatively quickly. Next image, please. So this is a sheep model actually. From a little while ago, but does a very good job of demonstrating the functionality and sort of how AngioVac works when it's actively engaged with a clot, and how it sort of works to pull it in further. And then we'll take a look at one that has more of a passive engagement that actually sort of catches it and brings it into the system, but gives you an idea of how these both work. All right. And this is the passive engagement. So this is tumbling around a little bit. Think your tumbling right heart masses, your right atrial masses, PE in transit. This is the same kind of idea. And obviously, it takes a little bit for the negative pressure to build and ultimately toothpaste it into the system. All right, great, thank you. Next slide, please. As we talk a little bit about, where AngioVac is actually utilized, we do cases in the SVC, the IVC, the right atrium, and really the two largest areas of growth really for AngioVac in terms of procedural utility is with tricuspid valve infective endocarditis associated with intravenous drug abuse, and with device-related infective endocarditis associated with defibrillators or infected pacemaker leads. So in both scenarios, ultimately what we're doing here is debulking or doing a basic vegectomy to kind of reduce the bacterial load in the system and ultimately allow antibiotics to be rendered effective. We'll talk a little bit more about that as we get into some of the disease state stuff and some case examples. Next slide, please. Here's just to kind of give everybody a picture of how AngioVac is used sort of in practice today. Obviously, a good chunk of our cases are in the IVC and SVC space, in that VTE space. More of the DVT, iliofemoral, large burden type cases. The other large portion of our cases are really in the right heart. Spoke earlier about some of the infective endocarditis stuff. The lead vegetation and tricuspid valve endocarditis cases are our largest growing portion of cases, and over the last fiscal year have been about 70% of our cases. So pretty nice mix of different types of applications and utility for the platform. And as we move forward and iterate the device, there's quite a bit of data coming out that will support some of these different applications and kind of give our users some confidence that these various applications are good homes for the AngioVac platform. Next slide, please. So as we look to sort of assemble more robust, formal, prospective clinical data, there is data out there for the support of AngioVac. If you do a PubMed search, obviously anecdotal, but there is about 70 references to AngioVac in the literature dating back to 2011. We just recently presented the largest single series of data in support of one specific application at the Heart Rhythm Society this past March, and that was a 100-patient series, all with using application during lead and device extraction. So pretty exciting to see some of this stuff come to fruition. And if we move to the next slide, another example of some of the work that's kind of completing. We've just finished enrollment at the UCLA Rapid Outcomes Database AngioVac registry, and we'll be working toward publishing the first year follow-up for the first 100 patients in the next handful of months here. But wanted to just put out the indicator that AngioDynamics is working hard to support the platform and make it clear that AngioVac does have a role in the toolkit. And while it's not a perfect device for every application, nor is any other, which is why we have and often take this toolkit approach for these types of cases, it does have a viable place in that bag and toolkit. So with that, let's go through a few cases and just give you an example of some of the stuff that we're doing with AngioVac. I'll kick off each section with a little bit of the disease state background, just to kind of give everybody an idea of why we're doing what we're doing. Next slide, please. So these are just some actual procedure results, obviously, dependent on individual user, clinical situation, et cetera, but examples of some of the stuff we see out there. Next slide, please. So for those of you who don't know, infective endocarditis is ultimately an infection and inflammation of the inner lining of your heart. Ultimately, as the disease progresses, it obviously becomes much more robust, and you actually see the destruction and growth of bacteria within the heart structures and the breakup and destruction of the valves and inner lining itself. And obviously see a pretty gross image in the background of what happens as we see this disease progress. There's a couple of animations along with these next handful of slides, so if you can kind of just click forward a few times so that the text pops up, that might be easiest. Next slide, please. Thank you. So this is a pretty serious event. Obviously, we see that as any type of material embolizes, we see mortality increase. And we really just see that as that material becomes infected, the risk of that material embolizing and being septic increases the risk for mortality, especially if we have to consider opening that patient up. Can you jump ahead 2 slides, please? Next slide, please. And if we take a look at what therapies are out there for for these patients, every patient involved or suffering from IE will be prescribed antibiotics on some level. Ultimately, the amount of disease and amount of bacteria in their system will dictate how effective these drugs are with combating that type of disease. And oftentimes, because of the type of patient that these folks aren't often great candidates for open surgery or follow-up or maintaining the cleanliness of their access sites, et cetera, et cetera. So oftentimes, this is the only option we have for some of these patients. And prior to something like AngioVac, it was often a risky open surgical procedure, antibiotics, or bust. So as we progress forward, as some of these epidemics continue to increase and become more of a social problem for our society, we need to come up with solutions to better manage these patients. Next slide, please. So mentioned earlier, aside from antibiotics, some of the options that these patients have are really just surgical. So considering that once septic material embolizes, and the increase in mortality, sometimes upwards of 50 or 60% in those certain situations, no one really wants to open up these patients if they don't have to. And that's really where AngioVac comes into play and offers a percutaneous way to ultimately debulk this material and move forward without having to crack open someone's chest. Next slide, please. Ultimately, the pathogenesis of infective endocarditis follows the path of some of our normal blood clots, clot cascade, right? And if we think about Virchow's triad and why blood clots often form, endocardial injury is often a reason that this will start and begin that clot cascade. And in this situation, that's no different. As the bacteria damages the structures within the heart, your body wants to obviously repair that injury, and blood clot starts to form in those areas. And obviously, as that blood clot mixes with the bacteria present from the infection, you start to see this vegetation form rather than just a true blood clot. And as that vegetation matures and gets larger, you see the bacterial load in the patient's system increase, and you start to see the destruction of the heart structures themselves. And that's where the system ultimately becomes overwhelmed, and where AngioVac comes into play to hopefully debulk that mass. Next slide, please. So just to wrap up some of the disease state summary, the right-sided infective endocarditis accounts for about 20% of all endocarditis cases. This stat used to be about 10%. But with the influx and the rate of the opioid epidemic and some of those challenges coming to bear, we've seen this the incidence of this on the right side, specifically with the tricuspid valve, increase pretty significantly. And unfortunately, a lot of these patients are intravenous drug abusers. So I'll give you a case example as we move forward here. Next slide. So this was a tricuspid valve vegetation, had a burden about 2 by 3 centimeters on the tricuspid valve. This is a 24-year-old male with a history of intravenous drug abuse. Presented to the hospital with a fever and wasn't responding, obviously, to his antibiotic treatment. The goal was ultimately to intervene with AngioVac to debulk the mass and try and minimize the impact to the patient. Next slide, please. So we utilized a 26 French gore dry seal sheath for access in the right internal jugular. They chose an 18 French reinfusion cannula into the right femoral vein, and ultimately were able to achieve a flow rate of up to 3.4 liters per minute. Use TEE to guide and navigate the procedure, and ultimately use a snare to help manipulate the device and remove the vegetation from the valve itself. Next slide, please. I believe this is a video, and it'll give you an idea of what the device, or excuse me, what the vegetation looked like on the valve as it appeared on the echo. If you could hit play, please. So you can kind of see the burden sort of flapping back and forth across the valve, back and forth, sort of prolapsing in and out of the right atrium and right ventricle. And we're able to get in there with AngioVac and ultimately debulk a good portion of that material. And you can see what we were able to remove on the next slide. So if you hit play, it's a little difficult to see, but you'll see it's kind of circulating in, kind of hitting the wall of the filter there temporarily. And then I believe the next slide will show what it looks like out on the table. So ultimately only a few centimeters in size, very different than the type of burden we pull out with some of the large DVT burden iliofemoral type cases, but making it its impact nonetheless. Next slide, please. So same idea. So the other side of the infective endocarditis world with respect to AngioVac is with respect to device-related infective endocarditis, right? Obviously, pacemakers, defibrillators, other intracardiac devices are there, obviously, to help and support the patient. But because it is a foreign body, it ultimately acts as a nidus for infection in the wrong circumstances. And as the population is aging and growing, the incidence of this type of infection is only going to grow, and we're going to see this type of problem occur more often. Obviously, there's changes in the works with leadless pacemakers and which patients are appropriate for those types of devices, et cetera. But for the time being, the leads will be something that need to be managed over the next bunch of years. Next slide, please. So just to paint the picture of how large this population really is, we have over 7 million people with devices in their bodies currently, with almost 1 million of those devices being implanted annually. It's a pretty significant number of leads to manage as we progress forward here, and as healthcare continues to improve and extend the lives of our populace. It places a larger burden on the devices and the demands for these devices as we get older, and ultimately creates opportunities for infection and whatnot to set in as these reside in these patients longer term. So that's the situation we're faced with, and we'll give you an example of a case here in a minute. Next slide. Here we just see that as we start to stack complications associated with cardiovascular devices, the incidence for mortality and the likelihood of infective endocarditis increases. And obviously, if we have no infection, the mortality for a pacemaker or defibrillator is very, very low, significantly under 1%. And then as we start to stack and Lego some of these challenges on these patients, the risk for mortality obviously increases. Next slide, please. Okay, so we have a right ventricular lead with a vegetation both in the right atrium and on the tricuspid valve. This is a 70-year-old male with a history of hypertension, diabetes, handful of heart attacks, and pretty poor perfusion. So he presented with infection secondary to the right ventricular lead vegetation. Access was done with a 26 French Gore dry seal sheath in the right IJ from the neck and a reinfusion into the left IJ. Obviously, imaging via TEE again, and a flow rate of up to 3.5 liters per minute were achieved, and they were able to manipulate the cannula to about 45 degrees to help target the vegetation that they were going after. Next slide, please. So we see here that you can see the lead in the general middle of the image there, and sort of the burden kind of tumbling a little bit just north east of it. as it's tumbling around in there. Next slide, please. And we can see here what was actually removed from from this patient. Looks like a little bit of a cast of the lead itself. Obviously, as we manage these patients historically, as we look to do some of these extractions, the historic pull and pray methodology would often just embolize this material into the lungs. And with the advent of procedures like AngioVac, we don't need to do that, right? We can park AngioVac in place as we're performing these extractions, whether we're utilizing another lead extraction tool to help free the lead from this material or not. But we can use tools like AngioVac and some of the other aspiration devices on the market to help facilitate the removal of this material to avoid sending it down to the lungs. Next slide, please. Are we doing okay on time?
Yes.
Okay, great.
Yes.
As we take a look at some of the other types of cases that AngioVac is used for, and really where the utility of the device really originated, is in the large vessel VTE type cases. So we'll talk a little bit more of those types of encounters and start it with an inferior vena cava case. So this was a 34-year-old woman, two weeks postpartum. She presented to the ER with chest pain after she was found down by one of her children at home. So the chest CT showed bilateral PE with clot originating from the right pulmonary artery, 3 to 4 centimeters from the bifurcation. So an additional scan showed that there was a large thrombus with attachment to the uterine vein, and a very risky candidate for thrombolysis. The risk is that we lyse the patient, and then the large burden attached to the uterine vein was broken off in a particular piece, and then ultimately traveled and potentially exacerbated the problem already occurring in her pulmonary arteries. So we see in the next slide what that looks like in her IVC, and it's a pretty dark shadow in the middle there that represents the burden. And we can talk a little bit about what was done in the case on the next slide here. So a temporary filter was placed suprarenal to protect the risk of knocking that loose. Access was done from the right IJ for aspiration, and for the right femoral for reinfusion, and utilized the left IJ for the retrieval sheath for the temporary IVC filter. Ultimately, the physician utilized a balloon to bias the cannula to one side of the IVC to help direct it to the burden. Obviously, any number of interventional techniques can be used to help get you where you need to go. We hope that as we move forward with new generations of the device, less additional manipulation will be necessary, but in this case, help the physician get where it needed to go. Next slide, please. And we can see here, if you hit the video, how clear the cava actually looks when we hit the play. You'll see a flush of contrast come through. So pretty patent vessel there, given how large the burden was where we started. So pretty significant clearing of the burden. And in the next, we'll see what we caught. So 2 filters, pretty standard for one of these IVC cases. The right heart cases typically use 1 or 2 filters. The IVC, DVT type cases typically utilize a handful. Ultimately depends on the amount of burden you're ultimately trying to remove. Next slide, please. So we talked a little bit about right atrial masses in the previous grouping of cases, but here's another example of a tumbling right heart mass. This was a 42-year-old female with a history of lung cancer. She had a port in place for the infusion of her chemotherapy, and ultimately, after her echocardiogram revealed an RA mass on her port, a number of options were considered to remove the burden. Ultimately, AngioVac was chosen to try and remove the material. Next slide, please. I'm not sure if this is a video, but it may play. If not, this is just a still image of a pretty significant burden on the tip of the port, and gives you an idea of what we're up against, or what we were up against. Next slide, please. So access with the 26 French core dry seal sheath in the right femoral vein, and left femoral for the reinfusion cannula. AngioVac was placed in the right atrium with attempts to remove the material. After the physician realized that that the material was pretty adherent to the port itself, they utilized a snare to help lasso the material from the port and ultimately pull it into the AngioVac system while it was on pump. In the next image, you'll see the post image and a pretty clear chamber of the heart. So pretty clean right atrium from where the case started. So pretty good work from the physician and their team there. And then next slide, you get to see what it looks like in the filter and then on the table. All right, next slide, please. All right, last case. This is just another example of really an SVC case that is traveling into the right atrium. This was a 45-year-old female post removal of a PICC line about a month prior. The thrombus was required on a follow-up discovered on a follow-up TE. They used a right femoral approach for the AngioVac system and found that it was adherent to the junction itself, and they used the left femoral vein to reinfuse. Ultimately, when they were able to get flow rates up and on the burden itself, it was pretty much aspirated relatively easily, but kind of gives you an idea of what methodologies are utilized to help facilitate the removal of some of these burdens. Ultimately, how mature, how attached, and how malleable the material is ultimately dictate how easy or difficult it will be to remove the device or remove the material, and helps assess the patient in general and whether AngioVac is the right device or whether one of the competitive tools are more appropriate for the patient. And ultimately, you're choosing the right tool or club from your golf bag to try and hit the shot you need to hit. And oftentimes, AngioVac is the right club, but you do have a lot of other options out there. If we go to the next slide, it gives you an idea of what the pre-image looked like here. If you could hit play. With that guy tumbling around, but attached at the junction. And then if we go to the next slide, you'll see what we were able to catch. So that's what I actually had for you guys today. If you had any questions, happy to answer them. But if not, I believe we're transitioning into a hands-on demonstration. And with that, thanks again for your time. Let me know if I can do anything else to help you guys.
Thank you, Peter.
Thank you, Peter. We appreciate it. I've got a couple of real quick questions, if you have just a minute.
Yes, sir.
Considering that this has to be done on a fluoro, I'm assuming that most of these cases are done in the cardiac cath lab or some type of a
yes,
room.
Yes, sir. Great question. Typically, these cases are done in the hybrid room,
yes,
just because it gives us the best ability to optimize the available imaging with the specialties that need to be in the room to support these types of cases. So in a perfect world, the cases are typically done in a hybrid suite.
And last question from me, and I'll give it to my colleagues. With this intervention, are you finding who takes control of this? Is it usually the cardiac surgeons, or is it the cardiologists or someone else possibly?
Right. So very interesting answer there. So ultimately, it depends on what application the facility is intending on using the device for. So if it's generally more of a VTE focused use of the device, more for the DVT, iliofemoral, IVC type cable cases, it's typically owned by vascular surgery or interventional radiology. And obviously, as perfusion is involved, cardiac surgery is often there to support the use of that resource, but also be there for cardiac backup if any complications should occur. And then on the other side of the coin, if it's a shop that tends to use AngioVac more in the right heart for the infective endocarditis, tumbling right heart mass type stuff, the cardiac surgeons, EPs, interventional cardiologists typically take the lead. And in the shops that really utilize it for multiple applications, depending on who, what the patient is facing. There's often a pretty collaborative approach depending on, what's best for the patient, right? If it makes sense for cardiac surgery and interventional cardiology to tackle it, so be it. If it's another combination of those specialties, sometimes that works also.
Excellent, Pete. Thank you very much.
Yes, sir.
Any questions from Tammy or Min?
I actually have one question. So the cannulation seems like it's probably standard procedure. Is there any additional training that someone who's interested in doing this, a cardiologist or cardiac surgeon or a vascular surgeon would need to do? Do you provide some kind of training for that?
As So a couple things here. Right now, every single case that we do out in the field, we offer in-person clinical support for. So as facilities or physicians and teams prepare for these cases, we offer a clinical hotline that they can reach out to, provide images to, speak with one of our clinical specialists so they can collaborate on the best approach for the case and help assess whether it is an appropriate use for AngioVac or not. Ultimately, we want what's best for the patient also, and if we don't believe that it's an appropriate use of AngioVac, or we believe that there may be a different approach that's more suitable, the AngioVac clinical team will recommend as such. And in addition to the clinical support on site for the actual clinical cases, when they show up to do that case, they will in-service perfusion, surgical techs, nurses, any other support physicians that will be in the room to help prepare everyone for how the case typically will go. And then from a training standpoint, we do offer AngioVac physician training. We typically hold about 4 classes a year regionally around the country. And if anyone is interested in those opportunities, we'd be happy to provide Joe and your teams the appropriate information so that we could offer that resource to you and your teams.
Okay, thank you.
I had a question. So, how many different type of different size for the access retrieval cannulas, AngioVac cannulas, do you offer?
So we only actually offer the one size AngioVac cannula, which is a 22 French cannula in the 20-degree tip or the straight tip. From a reinfusion cannula standpoint, you could utilize whichever reinfusion cannulas you utilize at your specific hospital. There is no one specific manufacturer that makes one that's better or worse than another. It's all preference. Typically, though, you're dictated by flow rates, right? So if we're aspirating at 22 French, as close to 22 French back in optimizes your flow rates. So we typically recommend something in that 18 French range, but we do cases with 16 and 20 French reinfusion cannulas on a regular basis.
Okay. Thank you.
Thank you. Appreciate it, Pete. Thank you very much.